Thanks to all the audience who follows our broadcast. We're live on the first day of the 2020 International Web-Based Neurosurgery Congress. Remember, we're streaming on YouTube Live too. We have the honor today of having Dr. Nader Sanai. Dr. Sanai is a well-known neurosurgeon at the Barrow Neurological Institute. He is the J.N. Harvard Professor of Neurological Surgery, Francis and Dion Najaf Fisher in Neurosurgical Oncology, Director of the Division of Neurosurgical Oncology of the Barrow Brain Tumor Research Center, and Director of the IWBNC Brain Tumor Center. Today, Dr. Sanai is going to share his lecture, Surgical Strategies for Insular Gliomas. Please type your questions on the Q&A section. We will read them after the end of Dr. Sanai's intervention. Welcome, Dr. Sanai, and thank you. You may go ahead and start.
Well, thanks very much for having me. Thank you to the organizers for putting this together. I've enjoyed the talk so far. Just listened to my friend and colleague, Ted Schwartz, who gave an exceptional talk. And then following me will be my friend and colleague, Mike Lawton, here at the Barrow, who will be speaking on aneurysm. My topic for this morning or afternoon, depending on your time zone, is insular gliomas and surgical strategies surrounding that. For those of us who operate in this space frequently, we know that insular gliomas share a special role within the world of brain tumors. They're not only unique in terms of their anatomical context, but there's a variety of different pathologies and types of gliomas that can occupy this space. I believe this is one of the more challenging intrinsic gliomas to handle. Part of the reason is that many of these patients present to us in relatively good neurological condition. These are indolent tumors in many cases. They're protected from the brain by a variety of boundaries. Here you see an MRI on a patient who had a motor vehicle accident in 1988, and you can maybe visualize a touch of flare hyperintensity in the left insula that wasn't called at the time. And then many years later, the patient presented with a seizure, but otherwise neurologically intact with a classic insular glioma. So these are tumors that really require our fullest attention. To approach an insular glioma, I think we have to take a step back and review some of the modern paradigms in decision-making for gliomas in general, extended resection in general, and particularly for insular gliomas, for low-grade gliomas in particular. We know now that early intervention for low-grade gliomas is the way to go. There have been prospective comparative studies like this out of Europe, published in JAMA several years ago, where in an observation-based fashion, patients were looked at either with initial biopsy or initial resection. And there was very clearly a difference in overall survival outcome for these patient populations. You had one hospital that tended to favor early resections, another that tended to favor watchful waiting, and it's pretty clear from the data which group fared better. This has been replicated in other European studies. Again, another prospective cohort analysis looking at resection versus biopsy and the timing of intervention and the relative benefit of early intervention. So even in the setting of an incidental glioma, the data favors early intervention, even in the absence of symptomatology. Now, once we decide to intervene, it's important to counsel the patients in terms of what to expect and what your goals are. It's important to review for yourself the relative benefit of incremental increased extended resection. And these are three of many, many studies out there that demonstrate to us that the more we push the extended resection in low grades, the better these patients will do. And of course, this has to be balanced against the risk of neurological morbidity. But an interesting feature of low-grade gliomas is that the surgical intervention not only has a survival benefit, but seems to have a benefit in the rate of malignant transformation. So what this really means is when you cytoreduce a low-grade glioma, you're effectively changing the natural history of that glioma. You're changing the microenvironment and the population of cells that remain, and what remains is less likely, up to 10-fold less likely, to transform in a given period of time. And this means the world of difference for patients and for your future management. Most patients that present with low grades, including the one that I used as a case example in the insular glioma, present with seizures. And so seizure control is paramount to their quality of life control. We know that extended resection improves this in addition to survival and transformation rates. This is a study from Johan Palud demonstrating very nicely in a large population of patients the fairly tight correlation between extended resection and long-term seizure control. And here are the seizure control categories by extended resection in the x-axis and Engel criteria in the different columns. So surgery is not only about survival benefit, it's also about quality of life. And in cases where there's an opportunity, you can really change the long-term history of the long-term natural history of a patient by going beyond the flare whenever possible in a low grade. Now, there are only certain locations where this is more likely to happen. This is a limited series from Hugh Defoe, who I believe is speaking tomorrow and is one of the leaders in the field in introducing this concept of supratotal resection. But when the functional boundaries permit, going beyond the flare can very much change the ability of this tumor to recur in a clinically meaningful way in the near or even in the long term. Today, though, we're not just thinking about gliomas in terms of WHO histopathology. We're thinking about them in terms of their cytogenetics and their molecular profiles. So all the data in the recent literature really points to an extended resection benefit, but these are based upon histology criteria and locations, like insular low-grade gliomas or hemispheric low-grade gliomas. But molecular subtype itself is yet another layer to this, and now we're starting to see the data giving us better granular detail in understanding extended resection when you're looking at a particular molecular subtype. So here, for example, in a series from our center at the Barrow, when we look at just purely 1p19q co-deleted low grades, these are oligodendrogliomas, we see the extended resection benefit for survival, but we don't see it for malignant progression-free survival. And this may be that the transformation rates for these tumors are so slow that it has to be followed over an ultra-long period of time. But it also may mean that different biological backgrounds for these tumors respond differently to your surgical intervention. And there have been other studies looking at these trends as well. What is clear is that there's a survival benefit and a progression-free survival benefit with extended resection in all molecular subtypes. So when we approach a tumor, we want to have an idea of what we're going to be able to accomplish. Now, at the end of the day, these are game time decisions in terms of extended resection in the operating room, anatomical and functional considerations that you have to incorporate into your decision-making. But there are systems in place, like this study from Montpellier and Amsterdam, that try to give you a probability of extended resection in low grades based strictly on anatomical location and what's known about functional boundaries in those areas. This is not something that you can hang your hat on necessarily, but it is something that can help with your operative planning and with setting the right expectations for the patient. So for low-grade gliomas, whether they're in the insula or beyond, early intervention is favored to biopsy or watchful waiting. Aggressive resection certainly confers a survival benefit, and interestingly, it also confers a malignant progression-free survival benefit, meaning it affects the transformation rates. We're now looking at extended resection in the context of tumor genetics. There's a recent study from UCSF and Mitch Berger that does that very nicely. But clearly, all of these extended resection efforts have to be balanced against the functional loss that accompanies an overly aggressive resection. Insular gliomas, just like any other anatomical region, can have its share of high-grade gliomas and glioblastomas, and I'll share with you a case example of that. The data for extended resection and early intervention, specifically biopsy versus resection for glioblastomas and grade 3s, is far clearer than for low grades. There is, in fact, level 1 evidence, such as this small prospective randomized study that was completed many years ago, showing a survival benefit that's pretty clear. And even though the numbers here are low in terms of overall survival, the trend is quite clear and still applies today. Probably the best data we have in terms of extended resection and the closest we have to a true piece of level 1 evidence is Walter Stumer's randomized control study looking at 5-ALA. 5-ALA, as you know, is a prodrug that's ingested and can give you protoporphyrin 9 fluorescence. This drug is FDA approved in the United States as well as across Europe and in other parts of the world. And it clearly confers an extended resection benefit and a survival benefit for patients that receive it. And here you see the effective doubling of gross total resection rates in this German study, as well as doubling of progression-free survival. And while this was not a study that was powered for overall survival, a subsequent analysis did demonstrate the commensurate survival benefit. Now, when we look across the spectrum of extended resection studies, they all tell us the same story, that we should be pushing for greater resection earlier in these patients. So that takes us to the question of how much should we be pushing for? What should be our minimum operative goal for these cases? And in glioblastomas, this is relatively clear. Here's a study out of San Francisco looking at an entire population of patients with varying volumetric extensive resection, and then identifying where the inflection point is. Where's the threshold at which you stop seeing a survival benefit? And that number very clearly across multiple studies seems to be in the order of 78 to 80% volumetric extended resection. That's true for newly diagnosed glioblastomas, and that's also true for glioblastomas at first recurrence after standard of care therapy. This is a similarly large series coming out of our center here in Phoenix at the Barrow, looking at first recurrence glioblastomas after the Stoop regimen and showing you this very steady incremental increase from 80 to 90 to 100% extent of resection. And so once again, the threshold here is about 80%. And study after study shows that there are thresholds to look at better or worse overall survival impact. This study, for example, in 2018 looked purely at grade 3 gliomas and identified a threshold based this time on T2 or flare signal, not T1 contrast signal, at 53% for these tumors. Now, there are some nuances in the value of your surgical operation. One such nuance is the question of whether IDH status for a high-grade tumor changes the value of your extent of resection. If you have an IDH1 mutant tumor, does it fare better or worse with a similarly aggressive resection? And does it help you in terms of resecting the flare? So the most interesting recent data I've seen on this is this study in 2019, basically looking at the ratio between contrast enhancement in a high-grade glioma and the flare signal around it, and identifying that when that ratio is closer to 1, meaning that there's some flare around the enhancement, but not extensive flare, it's cases like that where the flare resection, what they call proliferation dominant glioblastomas, where the flare resection seems to confer the greatest survival benefit. And in cases where there's a comparatively smaller area of enhancement with larger flare around it, those are cases where resecting that flare has incrementally less value for you and for the patient. So this is a way of stratifying your surgical goals for any patient like this. Greater extent of resection clearly is a benefit for the patient. We think of newly diagnosed and recurrent glioblastoma patients as needing an 80% volumetric extent of resection. If you look at the films and assess that you can't achieve that, then likely this is not a good candidate for maximal surgical resection, and you may want to pivot to more of a biopsy and then moving on with adjuvant therapy. And obviously, all of this matters in the context of the neurological status of the patient. A supratotal resection, but one that leads to a hemiparesis that does not resolve, is effectively you neutralizing the value of your extent of resection with the morbidity. So getting back to the insula in particular, we can then extrapolate these paradigms to this very unique kind of anatomical functional quadrant. We generally think of the approach to insular tumors as two dueling paradigms. There are surgeons that centers that are very comfortable with and advocate for transsylvian approaches. And there are also surgeons and centers that are very comfortable with and advocate for transcortical approaches. My personal practice is really 50-50. I think you need to be comfortable with both of these strategies equally well because each tumor has to have its own tailored approach. And the reason for that is frankly the morbidity of each approach. The fact that transcortical approaches through the wrong corridors can give you permanent deficits. Transsylvian approaches with associated vascular injury can also give you specific deficits. And so these need to be looked at in the context of the tumor's anatomy itself. We think of the insular glioma in terms of 4 quadrants. These quadrants are created by taking a plane that goes right through the middle of the sylvian fissure, and then an orthogonal perpendicular plane to that that goes right through the foramen of Monro. And if you create those 2 planes, you have 4 quadrants, clockwise starting in the upper left, 1, 2, 3, and 4. And each of these 4 quadrants then, and now you're looking at an anatomical view, each of these 4 quadrants have different considerations with respect to how well you can expose the insula with ease, what kind of surgical windows and degrees of freedom you will have. This is a study from Arnaud Benet, one of our residents here, looking at these different parameters in an anatomical dissection of the human insula. So let's take this now to a case example, a fairly typical case, a 74-year-old male who presents to you with right-handed, with hemiparesis on the right side, as well as some word-finding difficulties. He's a right-handed male and otherwise in good health. Anytime you encounter a case like this, there's a spectrum of options here, and they're not all wrong. Observation is always an option, although in this case, not something that we would advocate for unless there were other precipitating factors. A needle biopsy here for us would really be insufficient. The size of that lesion really requires cytoreduction. Going through adjuvant therapy without cytoreduction will be challenging in that case because of the swelling that ensues. Surgery can be done on this case without mapping, or you could incorporate motor mapping for the corticospinal tracts that are, in this case, primarily on the back side of the tumor within the internal capsule. Or, especially if you're going transcortical, you can incorporate language mapping because the frontal operculum is draped over this sylvian fissure, and it'll be important to identify where those language sites are if you're planning to go through that cortex. Now, here are 2 videos looking at similarly located tumors. One case going transsylvian, one case going transcortical. In both cases, simulation mapping can be valuable. In a transcortical case, at the subcortical level, when you get the backside of the insula approaching the lenticular striates, and then in a transcortical case, initially right off the bat, because we have to identify the safe cortical windows within and around the frontal operculum that don't affect language. And here you see us using the transcortical window on the left, the transcortical window on the right. You see on the left the descending corticospinal tracts being stimulated vertically as we approach lenticular striates. On the right, similarly, motor stimulation in the awake patient. So this can be done with a combination of anesthetic approaches. You can tailor your approach to the patient at hand. And in both cases, we had great radiographic results, which is what you want, great functional results, importantly, not just neurological, but neurocognitive. So when we recently looked at our institutional experience with insular gliomas, looking at the last 150 cases we've done through a combination of transsylvian versus transcortical paradigms, we see that these 2 groups of patients were actually fairly similar from one to the other, similar in tumor volume, similar in the zones where things were located, with some exceptions. We also achieved similar levels of success, whether you're looking at extended resection or symptomatic versus radiographic ischemia. Looking at ischemia in your postoperative images is not just about identifying large territory infarcts. It's also about identifying small hits to the cortex and subcortex that are simply a consequence of your manipulation and your surgical corridor. The fewer of these there are, the faster these patients will recover, even if they don't have specific neurological deficits. So as we looked at this population of patients, I think on average what we can say is that both approaches have merit, and both approaches in the right hands can be done successfully. There was one distinction though, which was insular glioma zone 2 tumors. So these are posterior superior insular gliomas, where if you're going transsylvian, you have to have a wide sylvian fissure split, and you have to pull up on that frontal lobe superiorly to really reach underneath and up through the sylvian fissure. You can imagine, just with the way I've described it, that that carries some risk. And we saw some evidence of this risk when you look at radiographic diffusion-weighted ischemia in these patients. And in the transsylvian corridor, it was nearly double, even though these patients didn't have diffusion-weighted infarcts that would lead to neurological deficits. There was clearly more tissue morbidity to this approach. So here we have the case that I showed you originally, that insular glioblastoma. In that patient, we opted to take a transsylvian approach, primarily because this was a purely insular tumor, and pure insular tumors really lend themselves to a transsylvian corridor. When the tumor is spilling out through the temporal stem into the temporal lobe, or spilling into the operculum, maybe through the fissure, those are cases where we tend to lean on the cortical windows more heavily. But here you see we have a typical pterional style craniotomy. We have lighted bipolars. You will never see any fixed retraction at the barrow. I haven't used it in the 10 years I've been here. But we're slowly dissecting through this corridor, taking care to preserve the integrity of the sylvian fissure architecture, and then getting into various windows of the insula itself. You see here that there's a fair amount of cautery happening. This is an older video, and I would say more recently, we've really leaned towards less and less cautery. And I would credit Hugh Defoe for really advocating for that, as have many other great surgeons. You really don't need to have a lot of hemostasis in these cases. These tumors will bleed, but it is venous bleeding. And unless the bleeding is obstructive to your ability to where you're at, you can continue and avoid the electric cautery and therefore avoid the risk of ischemia. Here you see that we're starting to use the ultrasonic aspirator as we go down toward the internal capsule. This is the part where we'll typically begin stimulating incrementally, stimulate, resect, and I'll get into our technique of stimulation in a little bit. But here, as we approximate the descending cortical spinal tracts and we see that wrist flexion, that's when we know that we've really pushed the boundary to the extent possible. So we move on to other regions until we get to that functional boundary immediately in all cases. And we make sure that we're looking underneath the lip. And this is where effective debulking of the insula creates more space and enables you to then look up and down so that you're not having any collapsed roof. As you can imagine, the intraoperative navigation is not terribly helpful here as you start to get more cytoreduction and the brain collapses. So here you have our radiographic findings, including the diffusion-weighted imaging on the right. As you can see, on these larger insular tumors, the transsylvian approach is also fairly easy because the tumor has made space for you. And it's really the smaller lesions in younger patients especially where it can be particularly challenging, and you just have to be extra cautious as you split that fissure. So let's talk about general paradigms to optimize your insular glioma surgery, which effectively mean general paradigms to optimize glioma surgery. We think about it in terms of 6 axes. Improving and employing your subarachnoid planes. This is where patient positioning is important. This is where subarachnoid dissection and the skills of a vascular surgeon are important. Selecting your planned point of entry. This is not always obvious. For many tumors, the point of entry is counterintuitive, But what you want to do is select a point of entry with as few peel margins of normal tissue between you and it. Positioning the patients so that you have lobes that drop with gravity whenever possible. Whether it's a Sylvian fissure or an interhemispheric fissure, this is always possible. And this really enables you to skip the fixed retraction, which simply just adds time, adds complexity to your operative environment, and in some cases adds morbidity. Fluorescence guided surgery for us is frankly standard of care. Now that ALA has been approved in the United States and obviously has been approved worldwide for many years prior, for us, any high-grade glioma gets it. Intraoperative ultrasound is a technique that I think has increasingly evident value, especially with the advances in intraoperative ultrasound today. This is not something that I use routinely, but I can see the value of it, and I'll show you why. And then obviously stimulation mapping, which frankly must be the part of the armamentarium of any surgeon who's a glioma surgeon. Transsylvian approaches we just discussed for the insula, and in particular, we know that for zone 2 insular gliomas, there's a higher association with postoperative ischemia. But this is a classic example, of course, of arachnoidal dissection being used to your advantage. The exposure does not need to be large. You don't need fixed retraction. You don't need a lot of CSF egress. You simply start with wherever you have an obvious arachnoidal separation. You can go proximal to distal or distal to proximal. But the key is, as I'm sure Mike Lawton will emphasize in the next talk, that as you get down past that superficial margin, you start to separate these arachnoidal planes with the shafts of your instruments, putting broad pressure on these two lobes so that it separates on its own, and not everything has to be sharp dissection. I think the tools you use are very important. Here, we're seated behind an operating microscope. Our hands are stabilized. We're using lighted bipolars. All of this just facilitates your ability to get the job done. Entry point selection, I think, can best be emphasized with this case. This is a juvenile pilocytic astrocytoma in a young adult in the pulvinar, in the posterior thalamus. And in this case, getting to this region safely is the whole operation. So we're taking a lateral supracerebellar approach. We're going supratrochlear, above the trochlear nerve. And here you see the first peel margin that we're entering is the peel margin of the pulvinar, which is eminently resectable, entirely safe to do. And so we've gone down this corridor without really transgressing anything that was abnormal or functionally significant. And especially in a case like this, you need a gross total resection because that can be curative. Here we have gravity retraction, which in this case is emphasized in this thalamic glioma with the interhemispheric fissure split. We typically will put one hemisphere down, depending on the location of the tumor. It might be right or left. Obviously, we like to do right side down whenever possible to preserve the integrity of the dominant hemisphere. Lighted bipolars, again, no fixed retraction. CSF egress enables more relaxation. And effectively, you have the patient with one side down. They're still in a supine position. They just have a bump and a head turn. And you get right into the lateral ventricle through the corpus callosum. You see that bulging thalamus coming from the wall. You enter it immediately. So again, the first peel transgression here after your Sylvian fissure split is really right into the tumor itself. And even in a thalamic glioma, some of these cases lend themselves to cytoreduction and aggressive resection. And for these patients, yes, they present with hemiparesis. Yes, that hemiparesis can worsen. But in this particular case, they also recover. And importantly, they get through their adjuvant therapy completely without having to abort because of peritumoral edema. I don't think fluorescence-guided surgery needs to be something we spend a lot of time on. It's self-evident. From my perspective, there's value to it in high grades, but we also use it off-label in investigational protocols for low grades using a handheld confocal microscope. 5-ALA is an exceptional drug. It's the only drug we know of that is purely specific for glioma cells. It is not a contrast agent like ICG. It's specifically a drug biomarker. So it's based on the biology of the tumor that it's helping you identify normal versus abnormal. And yes, for high grades, you can see it with macroscopic fluorescence, as you see here under blue light. But with low grades, you can also see it as long as you have the right device. And here we have an investigational device that we've developed with Jonathan Liu, who's a bioengineer at the University of Washington in Seattle, that not only shows us the tumors, but quantifies it. I mentioned intraoperative ultrasound. I think with the technology today, this is really just something that should be in most people's operating rooms whenever possible. Here you have a case of an insular glioma. You have intraoperative shift, which is always the case in low-grade tumors that are large, and so the neuronavigation is not that helpful. But as you visualize this tumor, you can see in real time with the Doppler flow these lenticular striates, and then as you resect this tumor, you can see how close you are to these lenticular striates, even if the navigation itself is not helpful. So I think this is an older technology that is now having a resurgence and certainly has a role in the modern era. Stimulation mapping, I think, is really standard of care for any eloquent glioma. The concept of just resecting the imaging abnormality just really does not hold up, and that's been demonstrated over and over again. You can have functional pathways running through seemingly abnormal tissue, and importantly, to get the most aggressive resection, you have to push sometimes beyond the flare to the functional boundaries. Sometimes the tumors lend itself to an en bloc approach, where you're going around the entire tumor pia to pia, and then mapping the lower cortex. Sometimes you have to create a series of windows, as Dr. Berger would call it at UCSF. The rationale for mapping is really self-evident. There really could not be more data to support this. A study that I often cite is from Philip DeWitt and colleagues, Hugh Defoe, Mitch Berger, looking at this meta-analysis of 6,000 patients and really showing us a couple key observations. One is that when you use mapping versus non-mapping in eloquent tumors, the mapping cases will have lower long-term rates of neurological deficits. They may have higher short-term rates because you're really pushing it close to these boundaries, but long-term the patients are going to do better, and it also enables you to push these boundaries, so therefore your extent of resection is better. So this data for me is self-evident, but it's something that I use when having discussions with patients. When I arrived at the Barrow 10 years ago, there really wasn't a formal mapping program here, and so I embarked upon the process with all of my colleagues here of building this program. And so I can share that with you and subdivide it into really 4 building blocks of creating a mapping program for insular gliomas or any glioma surgery. Neuroanesthesia is obviously your closest partner in this. It's important to find like-minded individuals that subscribe to this approach and want to get better at it. Case selection is critical and is oftentimes underemphasized when we see discussions from centers that are highly experienced. The mapping protocol itself varies from site to site, and there are a variety of good ways to do this, a variety of technologies to use, and it's important to do what's comfortable for you and what's within the realm of possibilities at your center. At our center, these are the general paradigm for awake mapping anesthetics. It varies from case to case, but these are the agents that we typically use. I'm showing you here the last 6 years of 10 years of experience with our neuroanesthesiologist. And each slice of the pie is an individual neuroanesthesiologist. And you can see over the years, we've started to consolidate the different anesthesiologists so that they each get more and more experience with more cases under their belts, and therefore better results for us. And we've seen these improvement in results as we've gone through the years. Myself, having trained in San Francisco with Mitch Berger, came into practice very comfortable with intraoperative mapping, but what I learned to appreciate is the value of the team and the fact that that is so responsible for exceptional results. It's not just about the surgeon. So here you see our intraoperative seizure rates 6 years ago and last year, general versus focal. We started off using intraoperative electrocorticography fairly routinely, and over the years that's declined, primarily because we've become better at avoiding after discharge potentials and avoiding intraoperative seizures, but also because it helps us become more efficient in the operative time. We've also become smarter in selecting cases for awake versus asleep. I showed you a couple examples of awake versus asleep mapping in insular gliomas. Sometimes these patients are morbidly obese and awake mapping is not a good choice for them. Sometimes they have baseline neurocognitive or psychiatric issues. All of our patients are screened by a neuropsychologist and a speech pathologist preoperatively and postoperatively. So as you can see, we've started to narrow down the window of patients that have awake craniotomies and started to lean more heavily on asleep motor mapping whenever it's appropriate, going from 17 to 35% of asleep motor mapping cases just in the last 5 or 6 years. And while there are many different ways to do the mapping protocol, we've tried to be very regimented, because when you're building a team and building a protocol and building a center for mapping, you need to have predictability. It can't be so artistic in the operating room. Everyone else in the room needs to know what you're going to do next before you do it. So we write everything down, and I'm happy to share with these protocols, and I have shared these protocols with many centers, but it gives the operative team an idea of not only what's going to happen, but when it's going to happen and how long that's going to take. So our general sequence of events is that the patient is positioned while they're awake. They may be awake or asleep at pinning. We then let them fall asleep. They're not intubated, but they're under conscious sedation. We register. We use local anesthetic at the pin sites, at the incision. We use a limited field block around the incision. And then we proceed with the craniotomy, and we anesthetize the muscle and dura before they wake up so that there's no pain when they wake up. And when they wake up, the dura is intact so that the patient can be encouraged to hyperventilate, decrease their CO2, relax the brain, and then when they're fully awake and compliant is when we open the dura. The cortical mapping will then begin at that point. We may let the patient drift off to sleep for tumor resection, and we may wake them back up depending on what we need to map subsequently. But we try to get all of the mapping done up front and just work on the planes that are truly of functional significance so that the patient can go off to sleep and the rest of the operation is simply a question of anatomy. Some of the keys in positioning here is making sure that the patient is in line with their body, that their chin, their chest, their hips are all pivoted in the same direction. Here we use a sled with a gel roll. We have all the pressure points padded. The patient is not taped down. We want them to feel comfortable. We have the navigation arm comfortably away from the patient so that if they move, they don't bump it. And we use a Layla bar to lift the drapes up above the patient. And there are many contraptions you can devise to visualize the patient. This is just something that we thought was simple and easy using existing equipment that almost every operating room has. You see the patient's chin is not too flexed, and you see that the patient is looking straight ahead. Their arm is relaxed and padded, and this is the arm that we're going to need to see. Their neck is extended and in line with their body, as I mentioned. And here you have a sleep motor mapping case on the right side, same exact paradigm. So we try to do the same thing every time to give us consistent results. That way the multidisciplinary team knows what they're supposed to do, and I know what they're supposed to do as well. For sleep motor cases, we'll use EMG motor mapping. For awake cases, we don't use any EMG. We have a neuropsychologist or speech pathologist in the room. They're the ones that already have a great relationship with the patient, and so they can see the patient can see them, it's reassuring. They take them through the testing. Obviously, the patient hears my voice, sees and hears the anesthesiologist as well. We have a device that we custom made that I can share the specs with that basically takes all the different information streams, the patient's face, the EEG, the EMG, the operating microscope, the navigation, everything gets fused into a single image that I can see. Because as I'm mapping, I need to see the patient's response directly. I can't just rely on someone else's impression. And when needed, we use electrocorticography. We used to use the crown, but now more recently we use strips. There are a host of technologies that help you do better glioma surgery. Functional MRI is one of them. We use functional MRI routinely, but we don't use it to make surgical decisions. We use it to establish laterality, We use it to see where the ballpark of potential functional sites are, but it's quite clear that the specificity of fMRI results is not nearly high enough to make millimetric surgical decisions. So I wouldn't advise anyone to do that. DTI tractography is more specific, and so therefore it can be more helpful, but yet, again, depending on how these tracks are gated, and it's changed from patient to patient and site to site, you can't make millimetric decisions of surgical resection based on tractography. You still need to use the intraoperative stimulation mapping. I mentioned the audiovisual integration with this device, enabling us to see everything all at once through a single image. And of course, we always want to push the boundaries, incorporating clinical studies, technology studies. This is a device that uses non-invasive Doppler to visualize blood flow changes in the cortex in response to SSAP stimulation, thereby giving you a proximity of where the somatosensory cortex is. This is the type of technology we need to help develop in the operating room. So putting these things together with tractography, this is a classic example of how that can be helpful. Here you know that the pathways are pushed laterally, but you also know that this tractography is not going to be specific enough to tell you if there's anything along the medial cortex. And in a case like this, going through the interhemispheric fissure and through the medial cortex is the safest way to resect this tumor, because going transcortically, it just takes you through a lot more uninvolved tumor. So here we have one side down, again demonstrating this retractorless interhemispheric approach. We cut the falx, a very simple thing to do as a right-handed person. It's just a series of cuts to create a trapdoor from right to left. And then we stimulate the mesial cortex to identify what strands of the cortical spinal tracts have been splayed by the tumor. And so we identify one window that has functionality, one window that does not. We use the lighted bipolar to get through the non-functional window. And we know that once we start to resect this tumor, on the back side of the tumor, we're again going to reach additional strands of the cortical spinal tracts. And so that is an opportunity for additional stimulation as well. Ultimately, this gives you a good resection with minimal morbidity. This is a patient who recovered very nicely. And the final point I'll make, as I kind of get close to wrapping this up, I think we're right on time here, is that the learning curve, as Ted mentioned before, cannot be underestimated. At our program, having had 10 years of experience under our belt, and today approaching and actually exceeding more recently 500 cases of mapping patients, we're still aspiring towards these highest levels of achievement that you see at centers that have been practicing this for 20, 30 years. And you can see our learning curve over the last 6 years with the improvement in our seizure rate, the improvement in our temporary and our long-term deficit rate. And you see on the right side, our current rates of about sub 5 or 4%, which is not the 1 to 2% that you see from these long-term mapping centers, but we, as will every center, get there with enough experience. So to revisit all of these themes, glioma management strategies are truly multimodal. It depends on your understanding of not only the anatomical context, the clinical surgical context, but the biology of the disease. A glioma surgeon is a glioma biologist as well as a clinician. Surgical strategies should be aggressive. They should be pursued early. Those are what gives you the best results for patients, not only in terms of long-term control, but in terms of morbidity. And we've revisited a host of intraoperative techniques and technologies that can optimize your results. These are things that you have to deploy to your comfort level, and you pick and choose. Not every case has to be a Swiss Army knife of techniques and technologies. And the Insula really epitomizes that, where you can have cases that are purely transsylvian, very classic Yassergill type approach, or cases that are truly transcortical, employing really the paradigms that we see from Mitch Berger and Hugh Defoe, for example. So with that, I will conclude. I'll thank you for your attention. I'm open to any questions. My contact information is at the bottom.
Thank you very much, Dr. Sanai. for such a wonderful lecture. I'm sure all the audience has learned from your robust experience. So we have a few questions from the public. I'm gonna read them to you. Do you have an age threshold to perform aggressive surgery in insular gliomas?
So the question is, do we have an age threshold for aggressive insular surgery? And the answer is no. I think age is a number here. You have patients who are 90 years old, but functionally they look like they're 60, and the opposite is true as well. So for us, the age is really irrelevant to the assessment. It's more a question of what's the patient's neurological status, what is their potential to go through adjuvant therapy, how aggressive does the patient and the family want to be. So there is no limit.
Okay, sir. Does chemotherapy have a role or rationale for preoperative neoadjuvant in low-grade insular glioma?
So neoadjuvant chemotherapy is something that's been described before from Hugh Defoe and others. The opportunity with neoadjuvant chemotherapy, specifically alkylating agents like Temodar, is that if you have a very diffuse, particularly low-grade glioma, where it's occupying spaces that you think are just functionally unresectable, there are some opportunities, and I think you really have to choose the right opportunities here, where you can use long-term neoadjuvant Temodar and see some reduction in the flare, and then in those cases go for a more aggressive resection. It's a similar concept in a different way of staging a resection where you let functional reorganization happen to therefore change the playing field. So we do it in very specific cases where we feel like a resection at this time will really not get us to the thresholds we need to for value. And so therefore we go with neoadjuvant, oftentimes temozolomide.
Okay. When you do subcortical stimulation, what are the responses that you're looking for?
So typically for us, subcortical mapping will either be mapping visual fibers, motor, or language. So it depends on the anatomical context. For motor function, for example, the patient might be awake or asleep. If they're awake, we can also do subcortical somatosensory. When patients are awake, we really rely on their reporting and our visualization of changes. But oftentimes it's their reporting that's more sensitive. When patients are asleep, we are often looking for EMG activation, which will be more subtle than visually seeing the muscle twitch. So it depends on the context.
Okay. For huge tumors, how do you define zone, as they seem to span more than just one zone?
That's right. Most tumors always span more than one zone. It would be rare to have an insular glioma that just occupies a single zone. In that case, it's oftentimes just a purely incidental finding. So we'll oftentimes describe the multiple zones that a tumor occupies, and if it occupies all four, we'll describe it as a giant insular glioma or a complete insular glioma. The fact is that for most of these insular gliomas, it goes beyond these zones outside of the insula, and so that's also something to note when you're looking at your cases.
Okay. Do you use intratumor radiation capsules?
Right, so I think the question is brachytherapy. Do we use brachytherapy, which is local radiation delivery in permanent implants for gliomas? And the answer is no, we don't. There really is not any compelling data for gliomas for the use of brachytherapy. There were studies many years ago from Penny Sneed and others at San Francisco using older radiation technology, but nevertheless, radiation is radiation in many cases. And those brachytherapy studies showed quite clearly that there's no survival benefit for gliomas. And in fact, there's a high rate of radiation necrosis that leads to some morbidity. Now, more recently, we're seeing new isotopes like cesium being used and being revisited. From our perspective, there's still no data on this for gliomas. It may be valuable for other tumor types, but we need to see more data on that before subjecting patients to that kind of morbidity and the cost associated.
Okay. During stimulation, awake versus asleep, how high do you go in terms of voltage?
So we use an Ogerman stimulator, and generally speaking, for an awake case, we start at about 1 to 1.5 milliamps per channel, 60 hertz frequency, positive polarity, obviously. and then we'll dial up in 0.5 milliamp increments. Generally speaking, for an awake, it's uncommon to need more than 2 milliamps per channel in our experience. If you do, then you're likely you have a patient that's not fully awake. Sleep cases are more challenging and will begin at 2 milliamps, but will go up to 6 milliamps per channel as the upper limit. But for those cases, it's really about getting the right anesthetic regimen so that your seizure threshold is higher than your activation threshold for the pathways.
Okay. During resection of insular gliomas, did you place an electrode strip at the motor strip and stimulate it in lieu of subcortical mapping?
So placing an electrode on the motor strip to stimulate, I think, is one way to do this, and it's not a practice that we employ, simply because we prefer to have the direct stimulation of where we're at. It is nice to know that the entire pathway is intact, and so therefore you can do that. But the fact is that you can do it both ways safely.
Great. Have you seen any cognitive or functional differences between transsylvian versus transcortical approaches?
So we're looking at our cognitive data now, and I would say the early data for us, at least in our hands, suggests that there is a slight advantage to a transcortical approach versus transsylvian for some neurocognitive outcomes. We think this is related to the ischemia that sometimes a transsylvian approach creates, as well as the amount of manipulation you need to have of the surrounding lobes as you're pushing and pulling them to get the right angles. But the fact is that, again, what I would emphasize is that both techniques can be equally effective with the right comfort zone.
Okay. Is interhemispheric approach your preferred route for thalamic lesions?
So I think the question is, because you cut off a little bit, is the interhemispheric approach our preferred access for thalamic gliomas? And the answer is yes for anterior thalamic gliomas, but for posterior thalamic gliomas, our preferred approach is a lateral supracerebellar through the pulvinar.
And what is your preferred approach in case of basal gliomas?
For basal ganglia gliomas, depending on what side it is, we oftentimes will go through a parieto-occipital approach, especially on the right side. There are various tubing systems that we're all aware of that can be helpful in these cases so that you don't have a lot of brain collapsing on you. But that trajectory, especially for large tumors that have made space for themselves, takes you right through the lateral ventricle and directly into that basal ganglia lesion. It's always important in those cases to know how far you're going to push it. There's nothing wrong with leaving a rind medially and against the brainstem, because what you're simply trying to do is get the patient out of trouble, get effective cytoreduction, and then get them through adjuvant therapy.
Okay. How do you get intraoperative confirmation of tumor removal?
So intraoperatively, we basically use 5-ALA and fluorescence to confirm extended resection. We have an intraoperative MRI at the Barrow, but we rarely use it because it adds a lot of time to the case. The other lesson I learned from one of my mentors, Robert Spetzler, with whom I did a fellowship when I first arrived here, is that there is really no harm in coming back to resect more tumor on a patient. It is comparatively easy and safe, and patients will always understand if you tell them in advance that there's a possibility that you may resect what you think is the complete tumor, get a postoperative MRI, and then realize the next day you need to go back. So that's the approach we take. In our experience, about 5% of cases require a reoperation the next day.
Okay. Which cases do you consider for biopsy only?
Biopsy only for us are going to be multifocal tumors, number one. Number two, tumors where the tissue diagnosis is unclear. And while glioma is on the differential, there are other diseases that are non-neoplastic on the differential. We also use it in patients that are extremely sick, oftentimes patients that have extreme cardiac issues or on multiple blood thinners that can't come off, things like that. But generally speaking, when we do a needle biopsy, it's with the intention to then come back and resect depending on what we find. So we use it very sparingly. but it is a very effective tool, and there's really very little downside to doing it other than the fact that the patient's going through general anesthesia twice.
Okay, what is your last question? What is your choice for adjuvant therapy, radiotherapy or SRS?
We use almost uniformly fractionated radiotherapy with IMRT. The data for SRS and gliomas is pretty limited. There may be a role for it in the recurrent setting, in particular cases where there may be particular areas that need attention and you can't re-irradiate the whole tumor. But even in those cases, you don't have the robust level of data that you do for fractionated radiotherapy that's conventional as part of the Stoop regimen. So we err on the side of caution and use these conventional devices, although we have 3 different SRS platforms at our center.
Great. On behalf of CN, I'd like to thank you again, Dr. Sanai. It has been a great presentation. We're really grateful and honored for your participation in the 2020 IWBNC. More than 600 people connected to your conference from over 100 countries. You're more than welcome to stay tuned to watch more lectures from other speakers. And in a few minutes, we'll have Dr. Lawton doing his lecture, 7 bypasses. So if the audience is interested to get the link, please follow the link pinned on the chat screen or check the agenda on our website, cnhus.com. Dr. Sanai, thank you.
Thanks very much, everyone.